Okay. So just to recap very briefly, in the clinical diagnosis, it is very important to look at the risk factor assessment as well. So one has to look at ocular cues. For example, in the lids, if there's any abnormalities, for example, exposure keratitis, any history of trauma or insect or chemical injury, contact lens usage, which is one of the most common causes of keratitis, particularly in the West, but in our country, trauma dominates. When there is a history of contact lens use, you would like to ask about the frequency of use, overnight wear, solution use, whether tap water was used for cleaning it, type of the contact lens, whether the person took a bath in the swimming pool with the contact lens on, or the use of cosmetic colored contact lenses in which the diagnosis may be delayed or patient may not have realized at all. Other ocular diseases which also predispose to corneal ulcers are viral and previous episodes, similar episodes, medications like steroids, medication allergies, ocular surgery, and dry eyes. Systemically, one must look for immunosuppression as well, malnutrition, vitamin A deficiency, HIV, or immunocompromised states. So the presentation is fairly straightforward. I'm sure most of you are familiar with it. Pain, redness, watering, mucopurulent discharge, photophobia, defective vision, foreign body sensation. Usually bacterial keratitis, the history would be for 2-3 days, not more than that. And along with that, there will be other signs like circumcorneal congestion, epithelial erosions, stromal edema, Descemet's folds, endothelial plaque, hyperpion, and anterior uveitis. So what are the special features related to certain organisms? The most common organisms identified in corneal ulcers are the strep and the staph species. So strep species can cause something called as ulcus serpens, in which there is a progressively infiltrating ulcer from the periphery to the center. Staph aureus usually is oval, yellowish white, opaque, deep with a stromal abscess. Staph epidermidis, again stromal abscess, but it's slightly less severity as Staph aureus. Sometimes it's just a superinfection over an erosion. Moraxella may be seen as a paracentral oval stromal ulceration with undermined necrotic edge and corneal perforation. Bacillus cereus, you will see stromal ring infiltrates. Nocardia again has a very atypical presentation, a wreath-like or necklace configuration with a brush fire border and pinhead lesions. Pseudomonas, one of the most dreaded organisms. It has a ground glass appearance, marked stromal melting and ring infiltrates. Klebsiella, when we grayish white pleomorphic separation with diffuse stromal pallescence. And then you have the non-tuberculous mycobacteria, which typically are described as a cracked windshield appearance seen post-LASIK cases, but that is not always the case. That said, it is near impossible to clinically distinguish between organisms based only on appearance, and it is not recommended to treat based solely on the clinical appearance. So one has to do the needful. But before you do that, you look for other things. The sclera should be examined very carefully for inflammation, for ulceration, thinning nodules, basically scleral involvement. Cornea, one must look for descemetocele or a perforation. Any inflammatory glaucoma, and that will also retard healing. Complicated cataract. And on B-scan, it is very, very important to rule out endophthalmitis in every case of a large ulcer. So what do you do? So when do you do a corneal scraping? Ideally, all ulcers should undergo a scraping. But particularly, suppose you have a very small peripheral ulcer, you might decide to go empirically with monotherapy. But cases where you must do scraping are the large central corneal ulcers, chronic and unresponsive to broad spectrum antibiotics, previous history of corneal surgery, patient is on steroids for a long time, and any atypical clinical features. The reason being that your empirical therapy may not work in atypical ulcers, and you really need to identify the organism fast. So you must go ahead with the scraping. So how do you do it? So the very basic requirement for the scraping is for these two things. There is a Sabro's dextrose agar plate and the blood agar and slides and the needles. One can also use 15 or 10 knives, and or blunt instruments. So use Paracane to anesthetize the eye, give it a minute, and then you can scrape. You can either use a blunt instrument initially, and if you think the yield is not so good, you can go in with a 15 or 10 blade, 11 blade, but please be very careful when using the blades because you should not end up perforating. If the patient is not comfortable sitting, you can even make the patient lie down and then take the scraping from the base and the edges. So what you do is first you put it on the slides for staining, and when you do that, you must always mark the area where you have spread it out so that the microbiologist knows that is the area to be examined, and also put a small mark there and label it for a gram staining and or for a KOH. Now you must take the scraping once more using another sterile instrument before putting it on the culture plates. This has to be done twice. You should not use the same thing that you have used on your slides. So you got to take new instruments, scrape again, and then put it in C shapes. Because if you see something growing along the C shape, that is the organism. Anything that doesn't grow along, they may be contaminants. So that is why it is important to put it in a pattern, right? So what is typically done? This is the very, very basic evaluation. So you routinely do a grams and a KOH. So the grams is a very good stain which identifies a host of bacteria. A good microbiologist may even be able to see fungal hyphae and acanthibacillus. It can be picked up, but though it is not the investigation of choice. The KOH will pick up any fungal hyphae or any acanthibacillus. Blood agar and SDA agar are the standard culture media which is done always. Additionally, one may use non-nutrient agar for acanthamoeba, or one may use special culture media depending upon the suspected organism. That usually this is done in conjunction with the microbiologist. So you may, if recommended, they may culture it further on chocolate agar for so many other organisms, or for particularly Neisseria, and for anaerobic organisms, cooked meat broth is used. Nocardia again requires specific media, but Nocardia grows well even on blood agar. It is seen as chalky white colonies, but special media are very useful. So these are the various media: chocolate agar, blood agar, everything I spoke about. Lowenstein-Jensen media is used for mycobacteria, but as of now, there are still better methods for mycobacteria, like your MG tubes or GeneXpert, but GeneXpert is not available for the atypical mycobacteria. So only scraping. So what else can be done? Suppose the scraping is negative and there is a progression of ulcer despite best antibacterial therapy. What can you do? You can take a conjunctival swab. Simple calcium arginate swabs sometimes are very useful. They might grow some atypical organisms. There might be some confusion, but some information is better than no information. Contact lens cultures are very, very important for contact lens users. The lens, the solution and cases, everything should be cultured. Anti-rich hemoparacentesis can be done for very thick exudates. We have done and identified nocardia through anti-rich hemoparacentesis culture. Corneal biopsy can be done in very extreme cases if nothing is growing, particularly deep fungal abscesses. Corneal biopsy is used. Usually a 6 or 8 cell suture is passed from the normal to abnormal area, and that is sent for culture. So what are the newer diagnostic modalities? Now these are, you have other things like immunohistochemistry, enzyme immunoassays, you have PCR and radioimmunoassay, but these are of limited role in bacterial keratitis. PCR is very often used in advanced centers for fungal keratitis and atypical organisms, but you have something called a MALDI-TOF. This is a new technology which is used in major centers. This allows for very rapid identification and speciation of bacteria. It is very fast and accurate, and though there's a high initial cost of equipment, once there, the speciation it comes right down to the speciation. You do not require that extra 24 to 72 hours, 24 to 48 hours for speciation and sensitivity testing. The Vitek 2 complements the MALDI-TOF system. It can identify microbes and perform susceptibility testing in 5 to 8 hours. So many advanced centers, many advanced institutes now rely on MALDI-TOF and Vitek 2 for bacterial cultures and sensitivity testing. Management, again, it's very straightforward. We are looking only at medical management first. So topical, you give antibiotics, anti-glaucoma medications, cycloplegics, and lubricating drops. Systemically, you may give antibiotics and anti-inflammatory drugs. But look at general measures are dark goggles, avoid direct exposure to sunlight, excessive eye rubbing, applying soap or direct water splash into the eyes, rest, good and timely diet, and hot fermentation. Now coming to the topical antibiotics. Peripheral ulcers not involving the visual axis, monotherapy with third generation fluoroquinolones like 0.5% moxifloxacin, 0.3 or 0.5% catifloxacin work very well. These have to be given on a 1 hourly basis, round the clock, very strictly, 24 hours, 24 times, has to be told very strictly to the patient. Patients who comply recover very fast. Larger and deep stromal ulcers, better to start with 2 antibacterials, fortified cefazolin 5% to cover the gram-positive, fortified topical tobramycin 1.3%, or gentamicin 1.3, or amikacin 1, depending upon this setup, community setup, hospital setup. This has to be again put 24 hourly, round the clock, once every hour. Patient has to be told 24 times, 24 hours. So no rest for at least 48 to 72 hours for 3 days. Once it starts getting better, you reduce it to 2 hourly. Targeted antibacterial therapy, culture insensitivity report comes in after 48 to 72 hours, and we then change the treatment as per the therapy. Other topical medications I just told you as per requirement, and if there's a good response to treatment, you will see a reduction in the pain. Patient will report reduction in the pain, reduction in ulcer size, blunting of ulcer margins, and there will be healing of the epithelial defect, hyperpyon will resolve, visual acuity will improve, and there will be some vascularization. Poor response, worsening of symptoms, increase in the size of ulcer, more feathery margins, stromal thinning, increase in the exudates, hyperpyon, perforation, all those things will happen. Scleral involvement can also happen. Systemic antibiotics are usually indicated in scleritis, endophthalmitis, and non-resolving and progressive ulcers. Fluoroquinolones are preferred because they have a much better penetration in the eye as compared to the other antibiotics. And other antibiotics are aminoglycosides or cephalosporin. Surgical, if there's an impending perforation, patient has to be told to avoid excessive coughing and straining, start AGMs. Small perforation can be dealt with glue BCL, but a word of caution. If you put in a small BCL, you may not know, you may not be able to assess the progression underneath the BCL. It might work counter to what you have been trying. Therapeutic keratoplasty is absolutely required in large perforations. Non-healing corneal ulcers for 2 weeks or larger perforations, you need to eliminate the focus, and it's essential for restoring the anatomic integrity. Surgical pearls, ERR, trephination of the host cornea, 0.5 mm margin clearance is required. Graft is kept 0.5 mm larger. Graft is sutured to the host with 16 interrupted, always interrupted, so that we can remove any infiltrates or any vascularized areas. Removing exudates from the anterior chamber and angle. Release of pus, peripheral iridectomy. Lens is removed if needed, but kept most of the time to prevent any progression to endophthalmitis. If PC is breached, then thorough antirectectomy with antibiotics posteriorly. Thank you.